Now let's talk about local anesthesia. So local anesthesia refers to a loss of sensation in a limited region of the body. So the mode of action of local anesthetics is that they bind reversibly to a specific receptor site within the pore of the sodium channels in nerves, and they block ion movement there. So when applied locally to a nerve tissue in appropriate concentrations, local anesthetics can act on any part of the nervous system and on every type of nerve fiber. So it blocks the action potentials responsible for nerve conduction. So it can cause both sensory and motor paralysis in the area, and it is reversible. And also, there is no evidence of damage to the nerve fibers or the cells after giving local anesthetics. So it acts at the cell membrane to prevent the generation and the conduction of nerve impulses. Of course, so if there is no generation or conduction in the nerve impulses, there is no sensation and also there is no movement. So that's how the anesthetic works. That's how you want anesthetics to work, so that you can do the surgery without the patient flailing his hand or because of pain or because of reflexes. So local anesthetics also block conduction by decreasing or preventing the large transient increase in the permeability of excitable membranes to sodium, so which is normally produced by a slight depolarization of the membrane. So this is due to the direct interaction with voltage-gated sodium channels. So how do they prevent the generation and the conduction of nerve impulses? After giving local anesthetics, the threshold for electrical excitability gradually increases. The rate of the rise of the action potential also declines, the impulse conduction slows, and the safety factor for conduction decreases. So this decreases the probability of propagation of the action potential. So the nerve conduction eventually fails. If there is no nerve conduction, there is no stimulation of the adjacent or the next neuron. So there is no conduction of impulses, so there is no sensation or there is no movement. However, local anesthetics also have undesired effects. It has undesired effects in the CNS because it can cause CNS stimulation, producing restlessness and tremors that may progress to clonic convulsions. And the central stimulation is followed by depression, and death usually is caused by respiratory failure. This is if it is given or if this affects the body systemically, or maybe it was given IV instead of IM only or local infiltration only. It also has undesired effects to the cardiovascular system because the primary site of action following systemic absorption is the myocardium, where it decreases the electrical excitability, the conduction rate, the force of contraction, and it can also cause arterial dilation. If you remember, lidocaine is also used for arrhythmias because it affects the heart. Local anesthetics also affect the smooth muscle, so it causes depression of contractions in the intact bowel and in strips of isolated intestine. It also causes relaxation of vascular and bronchial smooth muscle, although low concentrations initially may produce contraction. So the goal when using local anesthetics is to cause a loss of sensation in a body part without the loss of consciousness or without the impairment of central control of vital functions. So this is advantageous compared to general anesthesia because physiologic disturbances associated with general anesthesia are avoided, and neurophysiological responses to pain and stress can be modified beneficially. So local anesthesia can be given topically. That means it's applied directly on mucous membranes of the nose, the mouth, the throat, the tracheobronchial tree, the esophagus, and the genitourinary tract. Examples of topical anesthetics are tetracaine and cocaine. So these also cause vasoconstriction. Why is this good? Because this can be good because it shrinks the mucous membranes and it also decreases the bleeding. However, you have to take note that local anesthetics are absorbed rapidly into the circulation, even if you give them topically. So that's why topical anesthesia always carries the risk of systemic toxic reactions. So this should be used sparingly. Another topical application is when it is used for ophthalmic purposes. So example, proparacaine and tetracaine. These drugs are instilled one single drop at a time, and you have to take note that long-term administration of topical anesthesia to the eye is not advised because it has been associated with retarded healing, pitting, and sloughing of the corneal epithelium, and it predisposes the eye to inadvertent injury. Local anesthesia can also be given as infiltration. So this is the injection of the local anesthetic directly into the tissue without taking into consideration the course of cutaneous nerves. So you just inject it directly into the tissue. So that could be subcutaneous tissue or the muscle or the skin. So it can be superficial to include only the skin, but it can also be deep to involve or to include deeper structures including intra-abdominal organs when these are infiltrated. So the duration of infiltration anesthesia can be approximately doubled if you add epinephrine to the injection solution. So if you mix the anesthesia, for example, lidocaine, you add epinephrine, 5 micrograms per ml to the solution, it can double the duration of the infiltration anesthesia. However, you should not use epinephrine containing solutions, or you should not mix epinephrine to the anesthesia if you are going to inject it to tissues that are supplied by end arteries. For example, the fingers and the toes, or the ears, or the nose, or the penis. Because if you give epinephrine, remember epinephrine is a vasoconstrictor. If you give this, the resulting vasoconstriction may cause gangrene. So that's why it's not advisable to do this. So for infiltration, lidocaine and bupivacaine are usually used. Local anesthesia can also be given by field block. So this is produced by subcutaneous injection of a solution of local anesthetic to anesthetize the region distal to the injection. So the drugs, the concentrations, and the doses recommended are the same as for infiltration anesthesia. So the advantage of field block or using field block is that less drug can be used to provide a greater area of anesthesia than when infiltration anesthesia is used. A nerve block is the injection of a solution into or about or around individual peripheral nerves or nerve plexuses. The blockade of mixed peripheral nerves and nerve plexuses also usually anesthetizes somatic motor nerves. So they also produce skeletal muscle relaxation. So examples for this are blocks used on the brachial plexus, which are particularly useful for procedures on the upper extremity and the shoulder. So for example, if a surgeon wants to operate on the forearm for so the anesthesiologist can just do a brachial plexus block so that the patient will not feel the operation on the arm, but he does not have to be unconscious or suffer the effects of general anesthesia. You can also do intercostal nerve blocks, which are effective for anesthesia and relaxation of the anterior abdominal wall. You also have cervical plexus block for surgery of the neck. You also have sciatic and femoral nerve blocks for surgery that are distal to the knee. There are also other useful nerve blocks for individual nerves, like for example at the wrist or at the ankle, or blocks of individual nerves such as the median or the ulnar nerve at the elbow, or even blocks for the sensory cranial nerves if you want to do a very short and very localized operation, like for example say a removal of a small tumor or cyst in a particular area. Take note that the local anesthetic is never intentionally injected into the nerve, because this would be painful and this could cause nerve damage. So instead, the agent is deposited as close to the nerve as possible. We can also broadly divide the local anesthetics into 3 categories. So those with short duration of action, intermediate duration of action, and those with long duration of action. So when we say short, Duration of action, this is usually around 20 to 45 minutes. So for example, procaine. And we also have intermediate, that's around 60 to 120 minutes or 1 to 2 hours. Example for these are lidocaine and mepivacaine. And for those that are longer than 400 minutes, pila man na siya? More than 3 to 4 hours duration of action. So example, bupivacaine, ropivacaine, and tetracaine. We also have the intravenous regional block, or most commonly known as the Beer block or Bayer block. So this relies on using blood vessels to bring the local anesthetic solution to the nerve trunks and endings. So how is this done? An extremity is exsanguinated using an S-march or S-mark bandage. This is an elastic bandage and a application of a tourniquet proximal to the area where the surgery is to be performed. So the tourniquet is inflated to 100 to 150 millimeter mercury above the systolic blood pressure. The bandage is removed and then the anesthetic is injected into an IV cannula. Usually lidocaine is used without epinephrine. So this has primary disadvantages though because it can only be used for a few anatomical regions. So for example, a distal hand or distal arm or a below the knee surgery. Also, after deflating the tourniquet after the surgery, sensation returns quickly, so this is very painful. And if the tourniquet fails or there is premature release of the tourniquet, it can produce toxic levels of the local anesthetic because remember, it is given intravenously. Spinal anesthesia is also a local application of anesthesia. So this refers to injection of the local anesthetic into the CSF in the lumbar space. So that is below L2. So this is widely used because of the ability to produce anesthesia of a considerable fraction of the body with a dose of local anesthetic that produces negligible plasma levels. So this is usually used for surgeries involving the lower abdomen, the perineum, and the lower extremities. However, it's also important to take note that there may be cephalad spread or upward spread of the local anesthetic even if the anesthetic is injected below the L2. So this is of considerable importance in the practice of spinal anesthesia and it is potentially under the control of numerous variables. So the most important of which are the patient position. So of course, if you place the position in a Trendelenburg position or if the head is lower than the lower body, so by virtue of gravity, the local anesthetic may go to a higher spinal level, which is lower because your head is lower than the body. Okay? And also the other important variable is baricity. This refers to the density of the drug relative to the density of the CSF. But we will not be talking very much about that. Now, vasodilation is also known to occur. So, when this happens, it is the usual cause of hypotension. It can also affect the intestine, where it inhibits peristalsis and causes flaccidity of the abdominal muscles. Well, this is actually good because it produces excellent operating conditions for some types of bowel surgery where you want the intestines to not be moving and the abdominal wall is relaxed and it is there is not much resistance when you operate on through the abdomen. However, spinal anesthesia has complications and the most common complaint is postural headache. Of course, because you injected something into the CSF. So, and because it is continuous with your brain, there is a change in the amount of CSF in the spinal cord. That's why you will have postural headache. And it can also cause paralysis of the intercostal muscles. So this causes dyspnea and decreased ability to cough. So aspiration is a common complication. Another common local application of local anesthesia is epidural anesthesia. So this is administered by injecting local anesthetic into the epidural space. So it's also like the spinal anesthesia, but this is just inserting a catheter into the epidural space. So the current popularity arises from the development of catheters that can be placed into the epidural space. So if there is already a catheter, you can give continuous infusions or you can give boluses of the anesthetic repeatedly. So the primary site of action of epidurally administered local anesthetics is on the spinal nerve roots. So the most frequently used intermediate acting epidural is lidocaine. But if you need anesthetic for a long duration or for a long surgery, bupivacaine is used. So a significant difference between epidural and a spinal anesthesia is that the dose of local anesthetic used can produce high concentrations in the blood following absorption from the epidural space. This is something to take note of. That is why high concentrations of local anesthetics in the blood after epidural anesthesia make a particular concern, especially when you use it for controlling pain during labor and delivery, because the local anesthetics cross the placenta and then they enter the fetal circulation. So at certain concentrations, it can cause depression of the neonate. Another major difference between epidural and spinal anesthesia is that there is no zone of differential sympathetic blockade with epidural anesthesia. Thus, the level of sympathetic block is close to the level of sensory block. Let's now talk about the specific drugs or the specific local anesthetics. So the first is cocaine. So it's historically significant because it's the first local anesthetic. So the clinically desired actions of cocaine are the blockade of nerve impulses, as a consequence of its local anesthetic properties and local vasoconstriction. However, its use is limited because it has a potential for abuse. It has a potential for abuse because it has euphoric properties, and the euphoric properties are due primarily to inhibition of catecholamine uptake, particularly dopamine in the CNS. So it is currently used primarily for topical anesthesia of the upper respiratory tract, where its combination of both vasoconstrictor and local anesthetic properties provide anesthesia and shrinking of the mucosa. The most common is lidocaine. So it produces faster, more intense, longer lasting, and more extensive anesthesia than an equal concentration of procaine. So procaine is the first local anesthesia developed after discovery of cocaine. So lidocaine is available as a transdermal patch, as a occlusive dressing, or even as pills. So when you say pills, they're just like transdermal patches that are placed on the skin, and then they are removed, and then so these are usually for dermatologic procedures. So lidocaine is absorbed rapidly after parenteral administration and from GI and respiratory tracts. So it has significant systemic effects. Side effects of lidocaine seen with increasing dose include drowsiness, tinnitus, dysgeusia, dizziness, and twitching. Dysgeusia refers to a change in taste or a change in the sensation of taste. So as the dose increases, seizures, coma, and respiratory depression and arrest can occur. If you remember, lidocaine is also used as an antiarrhythmic agent, and it affects the myocardium. So bupivacaine is another local anesthetic whose structure is similar to that of lidocaine, except that the amine-containing group is a butylpiperidine. So it is a potent agent capable of producing prolonged anesthesia. It's actually known for its long duration of action. So its long duration of action plus its tendency to provide more sensory than motor block has made it a popular drug for providing prolonged analgesia during labor or the post-operative period. However, it is cardiotoxic. This is manifested by severe ventricular arrhythmias and myocardial depression after intravascular administration. So that's why this is something to look out for when using bupivacaine. Other local anesthetic for injection include articaine, which is an amide local anesthetic used for dental and periodontal procedures. It is used for its rapid onset and duration of action. You also have chloroprocaine, a chlorinated derivative of procaine, which also has a rapid onset and a short duration of action. You also have mepivacaine, an intermediate acting amino amide with pharmacological properties resembling those of lidocaine. Mepivacaine is more toxic to the neonate, so that's why it is not used in obstetrical anesthesia. It is also not effective as a topical anesthetic. Prilocaine, it is another intermediate acting amino amide with pharmacological profile similar to that of lidocaine. The primary differences are that it causes little vasodilation and thus it can be used without a vasoconstrictor such as epinephrine. So its increased volume of distribution reduces its CNS toxicity. So that's why it can be used for intravenous regional blocks. However, its use is limited to dentistry only because it can cause methemoglobinemia. Another is ropivacaine. So it is suitable for both epidural and regional anesthesia with a duration of action similar to that of bupivacaine. But remember, bupivacaine causes cardiotoxicity. So ropivacaine is a good alternative to bupivacaine. It was actually developed because of the cardiotoxicity of bupivacaine. So procaine replaced cocaine because cocaine became abused for its euphoric properties. But procaine had severe allergic reactions, so it was replaced by lidocaine. So ano na lang gyud ta? Replaced na lang gyud kung naibag-o nga mas maayo. The last is tetracaine. It is a long-acting amino ester, significantly more potent and has a longer duration of action than procaine. However, it may exhibit increased systemic toxicity because it is more slowly metabolized than the other commonly used ester local anesthetics. It is widely used in spinal anesthesia when a drug of long duration is needed. And we also have the EMLA or the EMLA, which actually stands for eutectic mixtures of local anesthetics. So this is made up of lidocaine and prilocaine for brand name EMLA and lidocaine and tetracaine brand name Pliagis. So this bridge the gap between topical and infiltration anesthesia. So the efficacy of each of these combinations lies in the fact that the mixture has a melting point less than that of either compound alone. So this exists at room temperature as an oil that can penetrate intact skin. These are marketed as creams that are applied topically. So they actually are able to produce anesthesia to a maximum depth of 5 millimeters. So it is applied on the intact skin under an occlusive dressing in advance of any procedure. So that's around 30 minutes to 1 hour before a procedure. That involves a depth of only 5 millimeters. So it's also effective for procedures involving skin and superficial subcutaneous structures, like for example, IV insertion or skin graft harvesting. But it's also important to take note that the component local anesthetics will be absorbed into the systemic circulation. So it can still actually potentially produce toxic effects if you're not careful. So lastly, here are just two tables that I will show you about agents used in epidural and spinal anesthesia. So you have chloroprocaine. It has a short duration, but epinephrine prolongs the action. Lidocaine has an intermediate duration. Bupivacaine and ropivacaine have a long duration of action. For spinal anesthesia, for short procedures that are 60 to 90 minutes, you can use lidocaine. For long surgeries or for long procedures that take up to 3.5 to 4 hours, tetracaine and bupivacaine are used. Okay, so that's it. I hope that somehow you learned something from my online lecture today. So see you when I see you. Stay safe, stay healthy. God bless you.